Recording.
Opnemen.
Oh, yeah, okay, fine, it works though.
Okay. I'm not that savvy on these things, but anyway, never mind. Okay, we'll give it one more minute, everyone, and then we'll kick off.
Okay.
If Carolina and Laura, if you can put your cameras on, and
Okay.
yeah, please, thank you.
I think I'm on now.
Yes. Good.
See you in your pictures, Carolina.
Yeah.
Would you have?
So, okay, let's get started. Good afternoon, everyone, or good morning, wherever you may be. This is webinar number 6 in the series of this year's World Continence Week 2023. I must say, highly successful so far, and today's webinar is a fitting end, I think, with our sponsor, Medtronic. Thank you so much, Medtronic, for all you do for us. This collaboration, we've been working now for 2 or 3 years together, and I think we're going from strength to strength with that. So without any more ado, because we have quite a full program, I'm going to introduce, first of all, Laura Thomas and Carolina Ochoa, 2 leading clinicians in this field of sacral neuromodulation, and they're going to tell us, I won't go through the program, I'll let you do that. I do have it here, but we can maybe put it up just to show people what we're going to do. And we're delighted to have also Trish and Linda, who've kindly given up some time to talk about their stories as patients. So we're very keen to hear from you. So I would say over to you. I think, is it Laura? Carolina first. Yes, thank you.
Yeah, I'm starting.
Very much.
Hi, Dean. Thank you very much for the kind introduction. So let me just share my screen so I can start. You able to see that?
Yeah, you just need to put it into presenter mode.
Good. Good.
Thank you.
Perfect. Thank you. So thank you, Lynn, and thank you for the invite and for giving me the opportunity to talk in that important week. I think it's very important for us to make sure everyone knows what we do and to make this as known as possible so we are able to reach more people and more patients and to help, which is the main idea. My name is Carolina Ochoa. I'm a consultant, urological surgeon in Bristol. And my job today is to introduce you to sacral neuromodulation, to explain a little bit what does it mean, when do we do it, what are the indications. So after me, Laura, our clinical scientist, she will talk about more about the patient management choices and everything related to SNS. And as Lynn said before, we have the pleasure to have 2 patients to see more close what the SNM experience looks like. So I will start now with the introduction to SNS. So the first thing I would like to say is that I have no conflict of interest at all giving this talk. And all this information is designed to help you to learn more about sacral neuromodulation. However, you will need to go to your medical, to your doctor to speak to your situation, and then be sure that we discuss everything today related to SNM. So what's the principle of sacral neuromodulation? So basically, the sacral neuromodulation is known as the bladder pacemaker. Give me just a second. Yeah, So it's known as the bladder pacemaker or pelvic floor pacemaker, and it's actually the size of the heart pacemaker. So what we do with sacral neuromodulation is to stimulate the sacral nerves. We stimulate peripheral nerves, so we are not touching the central nervous system. And then we go exactly to the nerves that control the bladder and the bowel function. We perform these stimulations in 2 steps. So the first thing we do is to do a test stimulation with an external device. I will show you a picture of this later, but this is for you to understand the whole process. So the test stimulation takes about from 2 to 4 weeks. And in that time, we make sure that this works in you before we go for the definite pacemaker implantation. And this is how it looks like. So basically, this is the battery and this is the lead. And then for us to then I can hear someone.
Perché niente? Ma no, ma perché niente la seduta telefonica? Non riesco a capire.
I can hear someone talking in the good. Perfect. So what we do basically is to implant the lead. And as you can see here, we put it through S3 most of the time. It really depends on the response.
Su una sola, in modo che se hai bisogno.
And then what we do is to stimulate that area. Okay, so this is how it does look like. And then you need to remember it's minimally invasive and it's reversible. Okay, so this is what we heard from our patients. So we know that incontinence takes your life away. Is that not? It does not kill you, but it may take your life away. And those are the most one of the most frequent things that we heard about from our patients. I can hear someone talking in the webinar. I don't know if you're able to mute yourselves, so it's easier for me to give the talk. Thank you. So this is what we heard from there. And then there is a nice survey that says that 44% of people feel embarrassed to talk about bladder problems. And more than that, 50% of people with incontinence never discussed that with a doctor before. So this is one of the main messages today. We're here to help you. We are fully trained, and then we are here to help you with incontinence problems. So please seek for help, look for it, and then we can for sure help you with that problem. Another important message is to tell you that you're not alone. So incontinence may affect people of all ages, so from very young patients up to elderly patients. And then we know that if we ignore those problems, those people may have problems with loss of sleep, loss of confidence, loss of self-esteem. So this is an important problem, and we need to really make that awareness. So what are the indications for sacral neuromodulation? So this is important because this is how you will know when we decide to treat people with SNM for urinary incontinence. So this is one type of incontinence, which is a stress urinary incontinence. Basically, is the leakage when you sneeze, cough, or laugh, and then when you exercise or do any activity, and this is related most of the time to sphincteric failure. And in that type of incontinence, SNM therapy is not indicated. However, there is the other type of incontinence, which is the urgency incontinence. This is the leaking before you reach to the toilet, frequent urination, and urgency to go. When you hear or touch running water, you lose urine. So this is when SNM therapy might be indicated. And then we always have patients in between. So we can have patients with both symptoms. And when the most predominant symptom is the one in the right, so urgency incontinence, SNM can be also indicated for the treatment of those patients. But SNM can do more. So we can also treat voiding dysfunction. It means patients are unable to fully empty their bladders and they have symptoms because of that. However, we need to carefully select those patients, and we need to make sure that those patients are not obstructed at all. Okay, so this is another indication for SNM. So you do know now indications. So let's talk about contraindications of SNM. So there are absolute contraindications. So the first one will be a negative test. So as I told you before we move to the permanent implant, we do a test. If that test is negative, so the response is no good, that would be an absolute contraindication of the use of SNS. The inability to operate the device, and I'm sure Laura will talk about it later. And then also pregnancy is another absolute contraindication, basically because we don't have enough evidence in pregnant ladies to recommend that. However, if a lady has a device and then get pregnant, we switch it off and then the pregnancy may continue without any problem. There are also relative contraindications. So basically neurogenic disease. This is another important point because the evidence that we have is not that much. And this is due to that because before recently innovations that we do have now MRI compatible SNM, as we didn't have it, so we didn't have enough time to demonstrate the indication in those patients. And then complete spinal cord injury might be another relative contraindications, and any anatomical malformations that will limit our access to the right position of the SNM will be another relative contraindications. So you will ask yourselves why SNM can treat various and opposite indications in pelvic floor dysfunction. So this is a nice picture to show you why. So this is the lead that it will go through S3 and then will touch the nerves. So we have here the sacral plexus, and then we have here the pudendal nerve. Okay, and here is our lead, and those are the electrodes that are producing the stimulation. So as you can see here, it may modulate both, and those are the responsible for the innervation of rectum, bladder, pelvic floor, and even the sphincters. So that's why through modulating those nerves, we can get to improve several conditions. This is the treatment algorithm for overactive bladder. So this is what we do when we have a patient with overactive bladder. First thing is to evaluate them, and then we offer conservative treatments, change of lifestyles. We do also offer pelvic floor muscle therapy if that's indicated, or bladder control strategies. If it doesn't work, so we move on to medication. Basically, there are two types of medication. We can try one, the other, and the combination. And then if it doesn't work, we move on to more advanced therapies. And this is when SNM comes. So we do have Botox, SNM, or PTNS as advanced options for the treatment of overactive bladder incontinence. So this is a nice slide that shows SNM and Botox as advanced strategies for the treatment, and this is the preference. So as you can see, it might be to one side or the other, but the most important thing is to remember that due to the different mechanisms of action, some patients may do better with one or the other, and those are the advantages and disadvantages of SNM, which is our talk. So the first important thing is to remind you that we have a test. That test will work as a prognostic factor. So before we implant the device, we will know if that may work for you. And then we can treat also voiding problems as discussed before and other pelvic floor dysfunctions. The disadvantages might be that you may require regular follow-up or revision
Un genio questa
if you do
relatrice.
have problems
Ha
with
fatto uno schema a 2 colori, non si
device.
capisce, non ha scritto qual è un colore o l'altro.
Can you mute yourself, please?
Can you mute yourself, please, Diego?
Thank you. So yes, those are the disadvantages.
Ah,
So
no, ecco,
we may need
adesso è
regular
comparso.
follow-ups and revision surgeries if we do have problems with the device. So when we decide to offer S&M to a patient, we need, as you already know, to go through the test phase. So it can be done in 2 different ways. This is what we do in Bristol, is the left one. So we do implant a temporary lead, which is a lead with 1 electrode at the tip. It's less invasive, less costly. It's easy for the patient as well, and it's easy to remove. So basically what we do is to implant this, test the patient, see if it will work, and then if it does, then we move on to the second stage, which is the definite implant. The test can be done also with the permanent lead. The difference is that the permanent lead will have 4 electrodes, so it will stimulate through the large area. And then the test success rate might be slightly higher, and then but it's more invasive. But the patient will, if they do respond, they need less time for the second surgery. So it really depends on the center. It might be done from either or the other side. Any of them is fine for the patients. This is just for you to know how the test can be done. And then once we know the test is fine, we will move on to the implantation of the definite implant. We do that in theater, most of the time under general anesthesia. We use a prone position, and the surgery will take about 45 minutes. It's always a day case procedure. And then we, as you can see here, that's a nice picture of the X-ray that we use. And then you can see here how the 4 electrodes go smoothly, and then it will go over the nerve that we are seeking to stimulate. And important to remember, this is not spine surgery. We are all the time stimulating peripheral nerves. We do have adverse events in SNS as well. You may have pain at the implant site. However, they have developed recently a smaller rechargeable device. Laura will go on to details, and it may improve that pain. Then the lead, it may move or migrate and then stop working. So if it does that, you may need reprogramming or even a revision surgery if it's necessary. The device may also infect, so have infections, and if it is infected, we need to explant the whole device. However, we can do a reimplantation later if it's necessary. And then the stimulation, I'm sure Laura will talk about it, but it might be uncomfortable. However, there are ways to deal with it. And then the explantation rates range about 3 to 19% of the patients. So as a take-home messages, I will say that S&M is an advanced therapy after conservative measurements and medication have failed, that the indication is for overactive bladder, so urgency urinary incontinence, as we discussed before, that it can be used for treating urinary retention, but remember, in carefully selected patients, that is a very good option for patients with double pelvic floor dysfunctions, for example, overactive bladder and fecal incontinence, a specific treatment of fecal incontinence. And then that the procedure may require 2 stages. So first test, we need to test first, know if it works for you, and then if it does, then we move on to the definitive implant. And then there are 2 different devices that can be offered. It might be recharge free, or rechargeable, and then it give us the possibility to personalize the therapy according to the lifestyle of the patient. So thank you very much for your attention. I think we will move over Laura's talk now.
Thank you, Carolina. Fantastic. This is just the second part of this before we get on to talk to the patients, which is for many the most enjoyable part of this session. But I've been asked just to talk a little bit about our patient management and patient choice. So now there's different devices available, how we help our patients make the right decisions. So I've been introduced before, but just briefly, my name is Laura and I'm one of the clinical scientists that works with the Sacral Neuromodulation team here with the support of our consultants. So in very, very basic terms, sacral neuromodulation comes in 2 phases. So for all of our patients, they will undergo a basic evaluation, which is a test phase. It lasts for a period of time that allows us to gauge whether there is an improvement in our patient's symptoms with this treatment option. So it's a test phase to be sure that we're offering the patient the right treatment. And for many it works, for the few it doesn't. It's a sad experience, but it gives us that information before moving forward with a permanent implant. So that's visible under the basic evaluation. And if we just switch over to the other side of the screen, we've got what the permanent implant looks like. So 2 battery options currently available, and I'll talk about them in a little more detail. You've then got the lead, which is a permanent one that will stay in, accompanied by the handsets that our patients will be using. And then this larger device at the back, surrounded by the blue outline, is the charging device necessary for the smaller micro battery. And that's what our patients will need to use to keep their battery firing. Okay, so this is the kit options for the trial phase initially, and then for the permanent implant. So in the last couple of months, there's been a slight surge, a slight change in the Medtronic equipment, and that's with the development of the InterStim X. So this is a next generation battery, which has a longer battery life than the previous InterStim 2 that they've had available. The theories that in some places it will last between 10 and 15 years versus the initial 5 to 7 that was on their original InterStim 2. But it also comes with the new and updated handsets. So the old ones are still in circulation with some of our patients, but for many we've moved over to the new handset. And the beauty of the new handset and their new kit is that it gives our patients the opportunity to have multiple programs available to them. So you'll hopefully hear from our patients a little bit later on. For those who are set up and embedded with their kit and their systems, they'll be happy on one particular program. But in the early days, there's a lot of tweaking that needs to be done to make sure that the patient's on the best program for their symptoms. And this device allows you to set all of those at one time, or a large majority of those, and then send your patient off so that they have the opportunity to try that themselves at home, rather than coming back to clinic and spending their time sat with me. So it gives us a different and a far more personalized treatment plan. The other thing that has changed in recent years, and Medtronic have plowed an awful lot of time, 20 years of research, and also an awful lot of money into developing a device that is now MRI compatible. So if we're thinking in very basic terms about implanting a metal device in someone, for a long period of time, these were not MRI compatible, which curtailed the type of patient that we could offer this to. With this advancement, there has definitely been a change, and now patients can have full body MRIs with standards and restrictions, but at 1.5 and 3 Tesla, which the radiology team will be aware of. But previously it was neck and head, now it's a full body. This change means that we can now treat far more patients. So just schematically, so that you can see the volume of patients across Europe who need MRIs. So this is a graph depicting the yearly numbers per 100,000 population that need an MRI. And you can see Germany taking the lead, very closely followed by Austria. But the highest, the high volume of patients that we would not have been able to offer this treatment to initially. And then Marie-Aimée and her French team have done some work looking at patients in their first year of treatment with the new SNS devices, and 18% of them had or were required to have an MRI. So that's a group of patients who maybe would have had to have the device extracted previously to allow them to have our MRI, or would not have been able to be implanted due to the need to have it. So all these advancements have meant that we can capture and treat a slightly larger population, which is fantastic. So if we go back to thinking about the types of kit that are currently available, the recharge system, which is the smaller one in our hand, looks a little bit like a USB stick. And then you've also got the recharge-free device, which is the slightly larger £2 coin if you're reading the Medtronic guidance size. Okay, so the difference really being that the recharge-free, the slightly larger one on there, doesn't need the intervention on a weekly basis. So the device is put in, and then when it comes to the end of its life, it is changed. So at the moment, that's somewhere about a decade. Okay. The rechargeable system, considerably smaller, and we'll talk about why that's beneficial in a minute, but it also doesn't fade. So like when you're plugging in many of our smartphones, time and time again, your battery depletes. You don't get that same fade with the battery that's in the micro device. There's also no concerns if you've had to have it off for a period of time. So Carolina touched on it earlier, but for our patients who are pregnant, we would ask them to switch the device off for the duration of pregnancy. And there is no damage to the device from not recharging it for that period of time. The theory is also that you can go from 0 battery to 100% battery in an hour of charging. And we will talk a little bit about the impact that that has. So it's all very well and good that we've got these options available, but what does that really mean, and how do we manage that? So for me, it means that the patients I see have a greater option. So previously there was one option and nothing else. Our patients now have a greater choice between company and also between devices. It also means that we as a clinical team can tailor the options that we have based on the patient in front of us. So if you come through the Bristol pathway, because is there any other, if you come through the Bristol pathway, this is what you're going to get from us. So if you are a patient in our service, you would have some form of diagnostic test first. Now, for us, the diagnostic test allows us to educate the patient. It also allows us to give the highest level of information so that the patient knows truly what they're consenting to and what the options are for them. If at the end of that consultation, and their diagnostic consultation, sacral neuromodulation is a possible treatment option, we will give them an information leaflet at that point. So we're thinking about already prepping our patient and making sure that they are given information early to help inform their decisions later on. So from that diagnostic, you will then put into a multidisciplinary team meeting. So one of the lovely things about this point in patient pathways is that by now, there's not a single person involved in this. It's a team of people working around to try and give the best level of care. So as a group, we get together, we have a discussion about you as the patient and work out whether this is an appropriate treatment for you. And it will be likely offered in combination with something else. So we would give you a selection of options. One of them may be sacral neuromodulation. If you decide that that's how you'd like to progress, you then get to spend a session with me going through what's available and what it actually means. So what will be involved from a patient point of view, and all of these different types of kit, because it's quite an overwhelming place to be. So it's really important for us that we give out that level of information as early as possible. Following that consultation with me, the first stage, that trial kit that we showed you in the beginning, that's done in an outpatient environment. So we implant this in an outpatient setting under local anaesthetic. So it's an hour procedure. The patients can bring themselves, they can drive themselves home afterwards. At the end of that trial phase, so once we've put the lead in before we send them home, we will go through and demonstrate once again all of the equipment that's available. And at that point, we might ask our patients to make an initial decision on what they're attracted to, what they think will work best for their lifestyle. No commitment at this point. It's just that we like to start pinning down those thought processes early on. The end of the trial period, the patients will come back for a review with us in clinic, and we will go through how successful we think it has been. So that will ultimately be led by the patient, because the patient will know whether they've had an improvement in their symptoms. But also we will ask them to fill in some questionnaires and some diaries to show and to kind of quantify the level of improvement that they've experienced. That's the consultation where they will make a finite decision about what device they want to progress to. And in that, we'd like it to be a final decision, because that's how we book their theatre cases from, making sure that we've got the kit available. But we will always check that prior to implant again, because what we can't do intermittently is to change the devices. So we'd ask our patients to make a decision on whether they would like a rechargeable device or a recharge-free device, because the leads will only fit into certain batteries. So the decision needs to be made. We can't just change it later on. And that's quite important to be thinking about when you're coaching your patient. One way that we use to make sure that our patients are fully informed is that we hand out decision aids. So anyone who's new into the system and is having that trial phase with us initially, they will get one of these decision aids. So, it's more information, isn't it? It's more information for everyone to deal with, but it goes through the current options that are available. And rather than the pros and cons, just the facts. So our patients have the best and the most amount of information to make those decisions from. Now, there's a huge move within the NHS and within our healthcare to make patient care personalised. So especially for us in this clinic here, I'm very aware of who my patients are, and it's a matter of making the decisions together. So this is about shared decision making and making sure that we're doing what's best for the patient as well as what's best for the service here. So what I think our patients need to know are, what are the choices? So what is available, but also, is this the only option? And also, does it even need to be done? Is your patient at a point where they maybe don't need it yet, but to be aware that it's available is hugely valuable. We also need to know what works well for each different device and what works well for each different treatment. So what choice do you have as the patient, or does your patient have? Okay. And then how are we going to support you to making that decision? And once you've made that decision, what is the support network like to ensure that this treatment is successful? And that very much is a toy up between the clinician, and I say that, thinking about more of our consultant decision making sometimes, and the patient. It's very much a fine balance, and it should always be heavily weighted towards the patient and what works for you. So this is just a bit of research that was actually done theoretically prior to the devices being readily available in terms of recharge and recharge free. But actually, our anecdotal evidence very much supports this. So this is looking at the sorts of patients that would benefit from different devices. And I'm very open with our patients about the experiences that we've had with other people, because without that, it's very difficult for them to make decisions. So if we're thinking about rechargeable devices and the sorts of patients that would benefit from having a rechargeable device versus the patients who would have a recharge-free device. So the recharge-free devices, the ones that we can put in and then forget about for up to a decade, those sorts of patients will be ones who actually probably have quite busy lifestyles and don't fancy carrying all the rechargeable kit around, so who don't have the amenities or the ability or the desire to charge it up on a weekly basis. It's quite a hefty bit of kit, so if you travel a lot, that will become problematic and probably quite irritating. For some of us, doing anything on a regular basis can become quite difficult. Taking medication, I'm sure all of us are guilty of not actually reliably taking that medication in accordance with our treatment pathway. And if you know that you are that sort of patient, then maybe having to recharge it on a frequent basis wouldn't work. So a recharge-free device might be better for you. Or if you're just someone that won't remember to charge it. So having to put something into your diary every week to do can become bothersome. It's something else. It's a constant reminder of what you've got going on, which for many, they don't want. Also, if we're thinking about how you recharge devices, if you've got something in your back and you spend lots of time sat in a wheelchair or are confined to a seated position, you can't charge it in that position. So I would sit with you as a patient and make sure that we'd adapted it so that to the best of our ability, so you could maybe charge in different position, but also whether that's something that you even want to be doing. Okay. The people who love these rechargeable devices are those who like to be continually in control of their symptoms and have a daily involvement. So you've got your handset, but also you can check your battery life, you can check your communicator. So those who are very tech savvy and like to be involved in it really enjoy the rechargeable devices. Patients who maybe have got other comorbidities, so we're thinking diabetes and things like that, that mean they're going to need a high level of stimulation for long periods of time, because the rechargeable has still got the highest and the longest battery life on it. Very skinny patients. So for those who haven't got a buttock to put the device in, the rechargeable one is much smaller, so those would benefit from it. Okay. And what we sometimes find is those who get pain, global pain conditions, find the micro device, the smaller one, slightly less invasive. So things to think about when we're coaching our patients, but ultimately giving the patient the final choice. And to bring it back into context to me and my clinics, we talked a little bit about the positions in which you charge. I've had a couple of patients say that the charger gets hot. So if you were to fall asleep over one of your iPhone chargers, that will also get hot. It's the same concept. If you overheat it, it stops charging. So that can become problematic. Think about where your patient's going to be recharging. Some of our patients, some of you guys have no problems doing it. You know, you put it on charge every week, and when you do, it's still got over half of the percentage left. In which case, can you maybe make it every 2 weeks? Can you extend that charge? Okay, so again, patient-clinician relationship to be able to have those conversations, but also for many of our patients, they're so switched on and so aware of everything that is theirs that they will make that adaptation themselves. There are a few, however, with the rechargeable devices who have had problems connecting up, because to charge it, you need to make a connection between the charger and the battery that's implanted. And sometimes that connection can be difficult to get, especially if the distance between the two is greater. So if the body weight changes, or if the orientation of that battery has altered so that it's not quite as easy to find. So if we're thinking about how how we manage patients, there are a couple of things that we tend to think about. Patient education is hugely important. This isn't just for SNS, this is for incontinence, throughout. And think about the way that patients like that information. So, are you a visual? Are you an auditory? Do you like it written? Do you like it on videos? How do you absorb that information best? Because an understanding of your physiology and how that directly relates to the symptoms you've got can almost be enough sometimes to help with these symptoms. I always look at patient medical factors, so anything else that's playing into that. So are there any other comorbidities that I need to be thinking about? And for incontinence, I know this is primarily urinary incontinence in regards to the service that Carolina provides as a consultant urologist. But this is a treatment for bladder and bowel symptoms. So this is a joint incontinence. So think about the patient that's sat in front of you holistically, okay? Patient expectations are key. And that's why these talks are important, because we're here to say this is something that's available to you. It's not a miracle cure, but the hope is that we can give you something that will make your quality of life a little bit better. And by putting patients in contact with each other, we can sometimes do that further, okay? Patient follow-up, that runs with me. So if you're a Bristol or near patient, invariably you get sent to me in my clinics. We're getting some extra support in here, but it's really important if you're thinking about running a service that you are always available for your patients. Okay, because a couple of days without this device can be very detrimental. Patient education tools, don't create your own. If you're clinical and if you're a patient, they're readily available out there. There are videos on YouTube. If you go onto any of the Medtronic websites, or even the bladder and bowel websites, or the World Federation for Incontinence websites, they're all available. So there's links to everything. Use it. It's all there. Okay. And then coming towards the end, we're thinking about what it is like on a day-to-day basis to live with these devices. So it's one thing living with your symptoms. What does it really mean to live with a sacral neuromodulator? So I run it, or I try to encourage people to run it just below where they can feel it. So rather than having a constant vibration, murmuration, to run it just subsensory, so just below where that level of awareness is, okay? but ultimately the patient can do what they want. So the patient has a handset that they will be able to turn the device on or off, or up or down, depending on what their sensory level is. I see people or speak to people every 6 months to a year, unless there are problems, and then they come to see me on a more frequent basis. I've got an exceptionally soft spot for all of my sacral neuromodulation patients, and therefore I would never be out of email contact or unavailable, hopefully, for any of them. And then there are some things that they need to think about in that professional golfers, I wouldn't implant. Patients who have got a love for deep sea diving, I probably wouldn't implant. So there are some other cautions that we need to give to those patients, but that's where your coaching and your consultations come in. So finally, before we move on to the mainstay, which is those patients that make our job so enjoyable, there's just some basic advantages of sacral neuromodulation, and it sits with the fact that there's some long-term research evidence that shows the success of this over a period of time. It allows us to treat holistically a pelvic floor patient. So for those who have double incontinence, we can target both with the same treatment option. You know, there are a huge volume of patients around the world with these devices in place, and it's been going for an awfully long time. But also there is a point where this is a reversible treatment. So unlike your major surgical interventions, this can be reversed at any point without major complications. So I'm just going to stop sharing my screen because Carolina and I have given a little bit of an oversight into sacral neuromodulation and how that impacts some of our patients. But what I really wanted, and what I think is the best part of this session, is that there are 2 patients who have dedicated an hour of their time to be sat here with us and available to answer any questions anyone has about this treatment option. So just to introduce, we have Patricia Smith and Linda Hall, who are 2 long-standing patients of ours at Bristol. Trish had her device in 2015 from memory, and Linda 2018. So, you know, significant periods of time that they've spent in our service. So have got all the gossip, if anyone needs it, on how we run or don't run our service. Might find out something I don't want to know whilst we're on the call today. But there are some questions coming through in the chat, and I will open that now, so feel free to add them in. But I wondered if we could just start, Trish, if you are there, with a quick or a very brief overview of your pathway and how you got to the point of sacral neuromodulation.
Hi, I'm just trying to get my camera working so that you can see me, but all I can get is my microphone working. I presume you can't see me.
I can't see you, but I can definitely hear you.
Okay.
I could paint your picture to everyone, but I'll let you talk.
I'm a 60-year-old female. Yeah, I can't get the camera on. I'm ever so sorry. Don't mean to be rude. I'm not hiding. So yeah, like you say, at 15, I had years and years worth of different treatments and trying. Oh, yeah.
We can see you now.
Can you see me? Lots and lots of different things, and sort of for a little while, and then when I went through the menopause, it all pear-shaped. So I was often after a lot of consultations, the Botox or
so I'm really sorry to interrupt you. I think maybe now we've seen you, the audio is not so good with the camera on. I wonder about if we just wave at you, and then I wonder if that would make it better.
Yeah, is that better?
That's amazing.
Well, at least you've seen me now.
We know that
That's
you're
better.
there. Thank you.
Yeah, thanks.
Yeah. So yeah, did you say just a quick overview? Yeah.
Yeah, give us an idea of how you've ended up with me.
Well, I mean, I've had problems since I was a child, and in the 60s and 70s, they didn't really know, well, my GP certainly didn't know much about it. So they just said, you've got a weak bladder, off you go and learn to live with it. And it wasn't until I was in my 30s that I discovered I had an overactive bladder, and it was a thing, and that it could be treated. So I started getting some help then very early on from GP and other areas. And things did work for a while, but it wasn't until things weren't working really well that I was actually referred to a consultant and offered these options, and I chose the sacral nerve stimulation. Sounded like it was a really good option for me, And that's when I met Laura and went through the process that she's described. And it's transformed my life, honestly. It's made such a massive difference. Yeah, just so many things that it's almost like a hidden disability, really, because there's so much you can't do. If your friends are going somewhere where there aren't any toilets, you go, oh, well, I'd love to go, maybe next time. You miss out because you know if there isn't a toilet nearby, that's not something that can go on your agenda. So it just opens up so many options that were closed to you before, and just makes you feel so much better about yourself. And instead of thinking all the time, constantly on your mind, where's the nearest toilet? How am I going to find the nearest toilet? What am I going to do? Don't even think about it, which is absolutely lovely. The freedom that you get is just, yeah, fantastic.
Oh, amazing. I'm glad we can do that for you. And Trish has just had a battery replacement as well, so hopefully another fair while before we have to do that again. Linda, I might just pop over to you because I know that you've recently had a new battery as well. Oh, there's Linda. Hi.
I have.
So I just wondered if you could let us know where, you know, how your pathway has been, how this device has worked for you, and actually how you've recovered from that surgery, which was weeks ago.
Yeah. Interesting, the algorithm that was shown was very much my journey, if I'm being honest, which really felt at the time, and even with hindsight, was long and protracted. Really the journey to recovery, if I use that terminology, commenced in 2004, but I'd had many years prior to that, after having my 3 children, where I suffered in silence, if I'm being really honest, and going from that position to where I am could be classified as going from something that was very life-limiting, in that my incontinence dictated what I would and what I could do. So it dictated, life really, versus having had the various surgeries that I've had, and now the SNM, to being life-changing. And I think that's from a patient point of view, I think that's actually really important. And my journey to recovery started in 2004, and I actually went along to see a surgeon with regard to having a hysterectomy. And in the weeks prior to leading up to that appointment, I had been trying to be have a more healthy lifestyle, and was going to the gym, and got to a point actually where I just couldn't go anymore, because it was becoming an embarrassment, because even doing the slightest thing, I'd come away soaking wet. And it was really just a casual comment in that consultation with regard to hysterectomy, where I mentioned the incontinence, and he said, oh, we could deal with that at the same time. And it was at that point, back in 2004, where I actually had a mesh sling inserted. I had a TVT, which unfortunately wasn't successful, then a TOT, and I have to say that was for the stress incontinence, and that was absolutely wonderful. Changed my life. I had 7 years of being incontinent free, for want of a better phrase, until such times, as many people know now, the mesh started to break down, and then all the old problems came back, and then that journey recommenced again. And I did have several unsuccessful major surgeries that were very physically intrusive, and it was when I actually met Professor Hashim, and he offered me some other alternatives from a surgical point of view, which actually resolved the stress incontinence. But however, on the back of that came the urge incontinence, which, whilst was not such a major issue as the stress incontinence, still was problematic. And in line with your algorithm, I tried all the medications, which helped slightly, and then was offered the trial test for the SNM. And I think I had that trial for about 4 weeks. And I remember going back and meeting Laura and Professor Hashim after those 4 weeks, and them saying, well, if you had to give us a percentage, how much do you think you've had an improvement? And saying, well, I would say 85% to 90% improvement. And they said, well, obviously that's what we're looking for, and that's a very good outcome. So, you know, you would think you were an ideal patient to have that. And I did have my first SNM implanted, as Laura said, in January 2018. And it has worked extremely well for me, right up until the battery ran out back in January this year. And then I had been 6 months without the device working because it had no battery power. And it was, and actually in some ways, I'm quite glad that happened, because it was a good reminder to me of why I'd had it done. And I actually had the InterStim X implanted just 2 weeks ago. Recovery is going well. And the device was switched back on 9 days ago. And immediately I can see again the benefits of having the device implanted, and have no regrets about doing that. Laura, I did have a little smile to myself when you were showing the pros and cons for whether you had a rechargeable or non-rechargeable device. Definitely got the non-rechargeable one because I'm definitely not thin. Do like to think that I'm a little bit tech savvy, but as I'm getting older, I'm sure I will become more forgetful about recharging a device. So it did make me smile a little bit.
In fairness, we wouldn't have been able to put it on your lead. So you know, the risk of moving it away, moving that lead out of a perfect
so it wasn't
position,
anything to do with not being thin.
to do with
Okay,
anything.
amazing, thank you. That's
Trish
why
is
you're in the
equally
job.
smiling.
That's
Yeah.
why you're in the job you're doing, the diplomacy. Amazing. As far as MRIs are concerned, I have to say for me, and it still remains the case for me because I've got the old lead, I still wouldn't be able to have a full body MRI scan, but personally that's a big tick in the box for me. Thank you very much.
No claustrophobic tube.
No
That's
claustrophobic
amazing.
tube.
And you've had a very long journey. I mean,
oh, amazingly long.
And it's for me personally, and I'm sure for the team, you know, with both of you, I've had a very long-standing relationship, and to be able to see you at a point where your life is manageable now.
Yeah.
You know, we're under no pretense that everyone is 100% better, but our role is to try and make your quality of life better. And you know, it's heartbreaking sitting on the NHS knowing that you're going to wait for 6 months to get a device. You know, for us and for you.
But I think that's a really important point, Laura, because I think from a patient point of view, from where I am, and I don't know if other patients would share this, especially when you've got something that is very long standing. And I think I did mention this to you actually in one of our communications. Yes, you've got a battery, it's going to last 12 years. I'll be in my 70s by the time that anything will be done with that. And you're very aware that actually from a consistency of care point of view, that the likelihood is other people will have possibly, probably moved on. So I think that's something that's really important for on a clinical side, which I'm sure is considered, that when these things happen, that patients feel that consistency of care, because you do know you've got something that is potentially lifelong, and you need to, and people like yourself are a bit like our safety net or comfort blankets that we know we can come to if something isn't quite right.
I'll give you both fair warning if I'm off anyway.
and building positive relationships is really important, whatever you do.
Thank you. Trish, whilst we're kind of on those points of building relationships, you are clearly in a very privileged position in terms of job and the understanding of where this fits in the pathway. But do you have any top tips for how to bring SNS into the conversation with, because I know you've previously seen patients in your role, you know, is there an appropriate time that you feel as a patient that you want to hear about it?
I mean, I don't know. I mean, like you say, I had a bladder and bowel nurse background, and I think I used to bring it into conversations myself when people had tried sort of the lifestyle changes and they go, oh God, this isn't working. And then they try the sort of the anticholinergic and other medications, and then they start to lose hope because they think there isn't anything else. And I used to say to people at that point, please don't panic. You know, we'll keep going with this, but if it doesn't work, there are other options you can explore, and they might include Botox, they might include the sacral nerve stimulation. And I say, you know, these things aren't for everyone and they don't work for everyone, but you know, there is more that can be explored to help you. Don't give up on your journey, because it is like, you know, the other lady said, it is you put so much into it, and it's a very protracted journey, and you have the hope that this one thing is going to work for you, and then you have the hope that the next thing's going to work for you, and then you have the hope that something else might work for you, and then you have the joy of it does work for you, and then you like the medication, and then after a while the side effects become really intolerable, and the effects wear off, then you're back to scare. After those living, just three ideas, like, when people know in your bit, but our other options, this is one of the one, but let me know if you'd like to find out a bit more about it.
And is it easy for you to understand where you refer on for that, Trish? So you're saying, get to the end of this pathway and there are other things available. Is there an easy route for you to refer in, or to know where?
You mean from the bladder and bowel service?
I guess, yes. So from a clinical, even from a clinical point, yeah.
Yeah, sorry, I didn't know what you meant there. So I suppose if somebody was talking to their GP, it would be a bit more tricky, but hopefully the GP would either refer on to the bladder and bowel service once the GP had done all that they can, either or to you yourselves. So either pathway could end up with you.
It's been an absolute asset then having you in that team to be able to distill that information, because I really feel like we think everyone knows about it in our specialist world here, but I'm very confident that it's not out there in the general public, and certainly
I don't think everybody does know. And I think
and certainly
because I know you're trying to get links with the bladder and bowel service, and I think that's so important.
Well,
they
through
know about you, and you know about them.
You have provided that, so that's a huge thank you to you, because I'm very aware that many GPs will not touch a patient because they just say to send them back to Bristol. One more question, Linda, whilst I have you here, and I'm conscious that you have other you're aware of other patients with sacral neuromodulators implanted. Is that an easy conversation for you to have with people? How does it come about that you bring sacral neuromodulation up in a conversation?
I think I make it a thing because I think there's so much taboo around incontinence, and there, as you demonstrated earlier in this meeting, there's such a high percentage of people who just suffer in silence with it. So yeah, I do make a point because I'm not embarrassed about it. And actually, when you do open up the conversation with people, they're generally fascinated. And I think for the other people on this call, just a funny little story really for people is the fact of, and about this, Laura, my son met his now wife 3 or 4 years ago, and when he first met her, she was telling him about how she had this implant, at which point he said to her, "Oh yeah, my mum's got that." And she said, "No, it's not funny." And he said, "No, seriously, my mum's got it." And it's just incredible how out of 375,000 people worldwide, he would find one of the others that had it. So, and I know that her experience also is one that is one that's positive. And so I think that also helps because you're having this continual dialogue with somebody else around, your situation with incontinence. So actually it just becomes a thing that you talk about, and we should talk about it. We really should talk about it.
Definitely. Carolina, did you have a question? Sorry.
Yes, I do. I would like to ask both of you, Linda and Trish, how did you decide to go through that route? So what makes you decide for S&M instead of other options?
Desperation, having already honestly gone through every other option: surgery, mesh, Botox, medication, another different kind of surgery. And it was kind of, I remember having the conversation with Hashim and saying, "Well, I guess that's it now. There's nothing else open to me. This hasn't worked." And he would say, "No, there is somewhere else we can go with it." So yeah, desperation really for a cure.
Okay. And then did you expect that result? What was like
I went into everything expecting a positive result, because if you don't, what's the point in doing it?
Trish, how about you? How did you come across SNS rather than Botox?
I was offered either one, and for me, my personal preference was to have something that was going to work long term. And even though the Botox is it's an attractive option and perhaps a little bit less invasive in, it's not surgical in quite the same way. After 10 months to a year, that'll wear off and you have to have it done again. And I didn't want to have to keep having to go back for a top up. Whereas if the sacral nerve stimulator worked for me, then I could forget about it for 5 to 10 years and just get on with my life, really. So that seemed like a much more attractive option. And also, being a bladder and bowel nurse, I knew that the risks with the Botox, if initially you can go into retention and have to do intermittent catheterization. And I mean, I could easily do intermittent catheterization, but I didn't want the risks associated with that and the kind of palaver really in my life if I didn't have to. So it just seemed like an easier option with a bit more input at the beginning. It's surgical and there's a recovery, but once that's over, you're like as free as a bird for a very long time, aren't you? And that appealed to me.
Wonderful, thank you. We are at time, so I feel like I'm going to be turned off.
I just want to say, first of all, this has been a really fantastic session. I wish we had more time than just this 1 hour. What strikes me is that how Laura and Carolina and Linda and Trish, the empathy and this sense of working together to get a better quality of life for you both, and how that sort of feeds back and forth. This is wonderful stuff. And in fact, I'm going to be calling on you. You don't know it, but I will be, because this is exactly what we need to get things like incontinence and the burden of incontinence out there, so that people realize just how much of a burden it is, and also all the various therapies and the treatment options that are available to help people. This week is specifically dedicated to that, to raise awareness and so on and so forth. All the recordings will be available on the WFIPP website. We'll also put it up on Support Incontinence, the other website, and I would just say, go out there, make a lot of noise. We need people like all of you who've been speaking today to get that message across, and I hope this helps in some way to doing that. So just to say a big thank you from WFIPP to Medtronic to the speakers today, and I wish everyone a very pleasant weekend, and thanks very much. Bye-bye.
Thank you, and thank
Thank
you,
you.
Linda.
Thank you.
Thank you.
Bye.
Thank you very much. Bye.